And it has a lot to do, particularly for healthcare providers, in trans elders not wanting to access healthcare. Some figures for you. 19% of trans people across a lifetime have had medical care refused to them. And there are instances where insurance companies have said that broken arm is related to you being transgender. We're not going to cover it. So there's been some really egregious stuff. 50% of trans people have had to train their medical providers on trans issues. So you're going in saying, this is the problem, and this is what I've researched on the internet, and this is what I think you should do, which some people might think is really exciting and exhilarating. And most of us, when we're not feeling well, want someone to take care of us, not be in a position of training them. And in terms of trans people postponing medical care, 28% have postponed medical care at some point due to mistreatment, and 48% due to inability to afford. That was before the Affordable Care Act picked up some of us, and we may well be returning to that soon. So there's lots of reasons why people resist even going to get health care.
I'm Dr. Regina Koepp. I'm a clinical geropsychologist, which means that I specialize with older adults and families. And this is the Psychology of Aging podcast, your go-to resource for mental health and aging. Welcome back to another episode of the Psychology of Aging podcast. This is a special episode because I am devoting this episode and the previous episode to Pride in honor of LGBTQ older adults paving the way for the rest of us to live authentic lives. Not only is June and Pride one of my favorite months, this is a big month for me because I have launched the Center for Mental Health and Aging, which is the go-to place online for the mental health care of older adults. So our mission is to make it easier for older adults and caregivers to get the mental health care that they need. And here's how we do it. We provide evidence-based information about mental health and aging, like what's typical with aging, what's not typical. We improve access to mental health providers who specialize with older adults with our national provider directory. So if you're looking for a therapist who specializes with older adults, a neuropsychologist who can help with dementia evaluations, or a psychiatrist who can help with some of the complex issues with medications and illness, then this is your place. And third, we train professionals like mental health professionals, senior living and senior care providers on the mental health needs of older adults and their families. To learn more, simply go to www.mentalhealthandaging.com. And of course, I'll link to it in the show notes. So today is a rebroadcast from an interview that I did back in November of 2020 with Loree Cook-Daniels. And I'll tell you in a minute more about Loree. But this is an episode on transgender aging in honor of Pride. And this is particularly timely because of the national use of they, them. I know I've heard from a lot of people the struggle to incorporate they, them into their daily vocabulary. And I want to just challenge us to see this change in vocabulary as a gift. I often struggle in a world that is so binary, like we have to choose this or that. The use of they, them, and seeing people and gender identity as more complex than you're either this or that. I think it's a gift that we get to expand our mind, expand our expression of self, expand our understanding of other people, to incorporate they, them. I don't always get it right. I make mistakes when I'm communicating with somebody that I care about who identifies with the pronouns they, them, maybe who identifies as non-binary or gender non-conforming. And even though I fail, and even though I make mistakes and misstep, I make a concerted effort to apologize quickly and correct it quickly. And the more I do that, the more I incorporate it. It's like learning a new language. The easier using they, them becomes. So let's try. Let's use they, them. Let's give ourselves permission to fail and give ourselves permission to apologize and make it better. Give ourselves permission to expand our view of gender expression and gender identity, and give ourselves permission to learn from Loree Cook-Daniels, from experts in the field who have been working in transgender aging for longer than I've been alive. I was born in 1976, and Loree Cook-Daniels has been working with LGBTQ rights since 1974. So let's take a listen. Loree Cook-Daniels has been working on both LGBT and aging issues since 1974. In the 90s, she was a primary staff person for the National Center on Elder Abuse. She founded the Transgender Aging Network in 1998, and in 2000 became the policy and program director for Forge, a 26-year-old national transgender and SOFFA, that stands for Significant Others, Friends, Family, and Allies, organization that specializes in transgender aging and victims of violence. Forge's Transgender Aging Network was a founding partner in the National Resource Center on LGBT Aging and remains its primary transgender expert. If you all haven't seen or been to the website, the National Resource Center on LGBT Aging, you have to go and check it out. Loree Cook-Daniels, thank you so much for joining me on the Psychology of Aging podcast today. I am thrilled that you're here. I wonder if you would start by sharing about yourself and the Trans Aging Network.
Thank you very much for inviting me here. I was a longtime lesbian with a partner that when we first got together, she told me that she wanted to transition to male. But this was in the 80s. And because I was a lesbian activist, I said, no way. So that's the way we left it for 9 years. And then when I finally saw the light and said, go for it, she did transition to male. And we did find some transgender community. Now, I had been doing LGBT aging work for 20, 30 years at that point. And people began to ask me about transgender aging because it made sense to them that I would know, and I didn't know. So I founded the Transgender Aging Network. This was in 1998 in order to try and network people who were doing research or serving trans elders or interested in the topic so that we could begin to collect our cumulative knowledge and start figuring out what we knew and what we didn't know. The listserv, that's what we were doing in the 90s. The listserv was open, and we had a number of trans elders join, which was no surprise. But what they wanted was for the physicians and the mental health care providers and the other people on the network to answer questions about their transitioning, which of course is really important, but I didn't set up the listserv so that professionals had to provide free consultation. So we quickly spun off Elder TG, which is another listserv that supports trans elders, and we define that as 50 and up, and close partners and family members. So we've had some siblings. We certainly have had a number of partners. And that provides peer support so that people are sharing their knowledge based on what they've experienced and other people that they've talked to. And that also was started in 1998 and is still going. And in fact, during the COVID era is, for some reason we haven't figured out, attracting a lot of new members. So
wonderful.
That's where we are.
And then what is the difference between the Transgender Aging Network and Forge?
So the Transgender Aging Network and Elder TV were both founded in 1998. And I moved to be with the co-founder of Forge in 2000. So at that point, we just pulled it under the Forge umbrella. Forge is a national transgender anti-violence organization.
Wonderful.
So it's mostly anti-violence work, but we have the Transgender Aging Network. We've got a support group for parents of trans children and youth. So we still dabble in non-victimization issues.
When we were meeting to prepare for this interview, you shared with me 2 important experiences to be mindful of when thinking about working with older transgender folks. You were sharing with me the difference between transitioning later in life versus transitioning earlier in life.
Yes.
And it really opened my eyes. And can you share a little bit about that with us now?
Yes. We are in a very kind of unique period of time because of the discrimination and actually the internet has a big part to do with this, in that trans elders, people who are elders now, grew up in some cases before even Christine Jorgensen. They didn't know about transgender people. They may have known that they didn't feel right. They may have called themselves of the other gender, but there was very little information and no social support for changing genders. So what happened was that when the internet started spreading, people had access to information that they had never had before. So many people found out about transgender people through the internet. The internet also spawned some other things, or it came at the same time, of like the listservs and the what did we used to call them, where people dialogued on AOL, those sorts of things. And so there began to be a lot more information and support for transgender people. So what happened is that for the people who are elders now, they lived a big chunk of their lives when there was no word for what they were, let alone support for what they were. And that's why we have a large percentage of trans people who are transitioning in their 50s, 60s, 70s, because it's the first time in their lives that they've really been able to do it. Now, there always were some really brave pioneers who did transition decades ago. And those people are now elders too. So we've got 2 different kinds, I think 2 different general character groups of trans elders. The group that lived most of their lives as the other gender, trying to, for instance, if they were born male, they often went into the military, or they went into really macho occupations in order to try and push themselves into masculinity. So that's one of the reasons we have more trans vets than the population. And of course, then we've got the other group that lived most of their lives in their preferred gender. So they have 2 different issues, or overlapping issues, but different issues. Obviously, the people who've been trans for decades have no need to be saying, how do I come out to my family, or where do I find a physician, or that kind of stuff. So that's often what happens on Elder TG is we get new people in and they're getting information on how do I start.
Yeah. And then the experience of transitioning earlier in life, how does that affect the aging process?
Well, some of the people that transitioned a long time ago survived by going stealth, maybe even to the point of where even family members did not know that they're transgender. So because almost none of those people have been able to surgically change their whole body, what that means is if they get ill or they need intimate care, they're at risk of literal exposure and being identified as being transgender. And that is very, very scary. It opens up the possibility of discrimination, which they've spent their lifetime trying to avoid by not telling people they're transgender. So as a result, we get some people that just refuse to have any kind of care at all, and would quite literally rather die than be in a position where their transgender identity might become known.
What a bind. I mean, what an emotional bind that you would, because the risk is you would be exposed and rejected, or exposed and humiliated, or
it's rejected, humiliated, made fun of. Depending on the caregiver, you might be exposed to religious exhortations. You're going to hell, you're a sinner. So there's a wide number of things that could happen.
So moral judgment and spiritual persecution.
Right. Also, one of the issues is if someone has been trying to keep their transgender history or status secret, one of the big issues is, are they going to out me? If somebody finds out, are they going to tell everybody else? So the potential for negative repercussions gets huge.
Yeah.
It's not just one person.
I've also had the experience of working with older transgender folks where they have successfully transitioned to their gender identity and have had affirming surgeries and have taken hormone replacement therapy. And then as they age, in combination with other medical problems and medications, have made the decision to stop hormone replacement therapy because of medical recommendations due to interaction effects and so on. And so then have the experience of some of the features changing.
Yes.
Which can be very upsetting and requires adjustment, I think, to the physical changes that happen when you have to stop hormone replacement therapy after you've worked so hard to have your appearance fit your inner world, your inner experience. And so have you noticed that? And how do you work with people on coming to terms with these transitions?
Yes. Now, anyone that has gone through menopause knows that hormones have a huge effect on people's emotions. Aside from all else, aside from how you're using the hormones, So yes, having to reduce or go off hormones for medical reasons can be really emotionally difficult. So yeah, that comes up on Elder TG every once in a while. So yeah, it's an issue. We also need to be aware of the tendency of even healthcare professionals to believe that every problem a trans person has is related to their hormones. So we have to be careful when we work with people to ensure that, yes, this is the hormones. The community just recently lost a very beloved leader at age 58 to blood clots. And she used to smoke. And those two, the female hormones and smoking, are really dangerous for blood clots. Mm. And yet, on the other hand, other people have died of blood clots. So sometimes that there's also a tendency to believe, well, that had to be a hormone problem, when in fact, no, it's a human problem.
Yes, and she knows the risks. She gets to decide.
Right. Yes.
And I think the other piece that I notice in mental health work is that not all mental health problems are a result of gender identity. That people can have frustrations with their partner or their other issues, and that is not connected necessarily to gender identity. That's connected to the relationship or all sorts of other things.
I had a common soapbox for quite a while about, just because you have depression and are transgender, settling into the gender you prefer is not necessarily going to take away the depression, because my concern was we have such a high rate of suicide in our community. And if you go to all the work of changing your gender in some way and then end up still depressed, I was afraid that was adding too much. So we've done some work trying to get people to recognize that depression and anxiety can be related to not being who you want to be, or who you think you are, or who you are. They can be separate as well.
Yes. Since we're talking about mental health concerns, can you share a bit about some of the mental health concerns that older transgender folks do experience?
The big ones for the whole lifespan of trans people are depression and anxiety. And I haven't done the comparison to see how much more we have than the general public, and it's going to be really different in COVID now. But depression and anxiety are big ones. And in fact, almost every youth in where the parents are in my support group, almost every single one of them has depression or anxiety or both. The suicidality is very high. 41% of trans people have attempted suicide at some point in their lifetime. And then the other note that I made for this call was, people are not paranoid. They are worried. They have a real fear of what other people are going to do.
I'd say justifiable fear.
Yes. And that tension, we call it minority stress, but it's very wearing. It definitely can contribute to depression and anxiety. And I think I have begun to consider the possibility that the last 4 years, the number of official acts that were anti-transgender may be pushing us up to something that I can't even, some level of feeling under siege that we haven't seen before.
Yeah, the level of collective trauma is so high.
Right.
Yes.
When your own government is very clearly against you.
Right. And potentially community. And I mean, it must be terrifying at some level. And it's not paranoia if it's true.
Right.
Right. So maybe it's at levels of intensity.
Yeah.
And I'd say that's probably a fair response given the level of trauma that transgender folks experience on a large scale.
And it has a lot to do, particularly for healthcare providers, in trans elders not wanting to access healthcare. Some figures for you: 19% of trans people across a lifetime have had medical care refused to them because they're transgender.
Wow.
And there are instances where insurance companies have said that broken arm is related to you being transgender. We're not going to cover it. So there's been some really egregious stuff. 50% of trans people have had to train their medical providers on trans issues. So you're going in saying, this is the problem, and this is what I've researched on the internet, and this is what I think you should do, which some people might think is really exciting and exhilarating. And most of us, when we're not feeling well, want someone to take care of us, not be in a position of training them. And in terms of trans people postponing medical care, 28% have postponed medical care at some point due to mistreatment, and 48% due to inability to afford. That was before the Affordable Care Act picked up some of us, and we may well be returning to that soon. So there's lots of reasons why people resist even going to get health care.
Yes. And then that, I imagine, increases rates of disability in older adulthood, and then increases care need if you have higher levels of disability. And we know that preventive medicine and engaging in the healthcare system for medical treatment when we have medical needs helps to prevent disability. And so if there are all of these barriers for older transgender folks to getting to the doctor and then receiving affirming care when you get there, and those are barriers, then and then there's you identified the socioeconomic factor, which is not being able to afford it.
Right.
And there is a long literature describing discrimination in workplace for transgender folks. And so access to jobs and equitable access to jobs, even you were describing as a lesbian woman experiencing discrimination, and rates of discrimination are higher for transgender folks. Mm-hmm. And then that affects, income, and income affects your ability to afford healthcare, and it's just a domino system.
Right.
Now, family relationships are also really important when we talk about deepening our understanding of the experiences of older transgender folks. Can you share about older transitioners and common family dynamics?
Well, the big one is the partners. Because what happens with the partners, and this is not understood even by some trans people, because our sexual orientation labels are so binary, just like the gender labels. When a partner transitions genders, go from one gender to the other binary, what that does to the partner is changes their public sexual orientation. So, for instance, when my partner transitioned from female to male, we went from a visible lesbian couple to one that looked heterosexual.
Right.
Which meant that I had to give up or constantly fight for my own identity. And that's a real issue, particularly for, let's say it's a woman a 55-year-old woman whose husband transitions. And she's always been brought up to think that gay people were some other species that weren't as good. And now she's going to be seen as a lesbian out in the world. That's a big issue. And the irony of the transitioning person gets to be seen in the world the way they want to be seen, and the partner loses exactly the same thing.
Wow.
So there is a tension there that I think we don't talk about enough, because often the spouse is told, they're told two binary things. One is you absolutely have to leave because obviously you can't, this marriage can't survive. Or they're told by those of us that are more socially advanced, maybe, that you should be supporting your partner. What's your problem? And there isn't enough awareness of the cost to the partner, in my opinion. The other thing is that people really do have sexual orientations, as in, this is the kind of body I want to be next to at night. And some of us can switch and some of us can't. And, that's not always given enough respect either. Although they can change. Early on, I was a peer with a lesbian woman whose partner transitioned to male. And I would get off my conversations with her and say, this is never going to survive. She's not going to make it. Not judging it, but just not judging in a negative way, but judging like, oh, there's too much here. She's too settled in the lesbian mode. And she did make it. And they were very happy. So, sometimes people switch even when we think they're not going to.
This tension that you're talking about is so profound. I am just struck at, I have heard those binaries. There's really nothing in between. Either you stay with the person or you don't. Either you come to terms with it or you don't. And I appreciate that it's the transitioning partner is moving into the identity that they identify with and long for and feel most authentic in. And then the partner has to also shift. The tension, I think, and friction is so important to hold space for, because I think if we don't hold space for it, it is less likely to succeed. It's less likely to help the partner to work through and sort of grieve some aspects of that, the partner's life and identity,
right?
For in support of their partner and in support of themselves. So there are lots of emotional and identity journeys that we're talking about, and then relational journeys that we're talking about. And I thank you for sharing that with us, because it's helping to deepen my own understanding and to hold space for people's unique experiences in the same relationship.
Right. And often if the transgender person often the transgender person believes that if I can convince you why I believe my gender, then you'll go along. And there is a relationship issue here that's far beyond that, which does go to my second point about the adult children. When you're transitioning older, your children are often adults. And whether they accept the transition or not is kind of a toss-up. We don't have the actual statistics, but some children get on board and some children do not. And we have not really studied about who is who, but that's just like the general public. Some people can get their minds around it and some people cannot. But what does happen is if there are grandchildren, if the adult child does not approve of their parents' transition, they may cut the grandchildren off. And that is one of the worst heartbreaks that I see on Elder TG, is the grandparents that can't talk to their grandchildren, that there is a level of pain in that that seems to be incredibly high.
So much grief and a loss of legacy, and that, parenting is hard. I think grandparenting is when you get the real,
right. You get the real back.
Yeah. It's like the icing on the cake, it's hard to make the cake, but then you just smear the icing on, and, yes, so much grief and loss and missed opportunity and loss of legacy.
Yeah.
Earlier, we talked about some of the barriers to engaging in mental health care and medical care. When we were preparing for this interview, you brought up such an important topic about the complexity of having mental health providers in the role of gatekeeper for transitioning. Can you talk a little bit about that?
For many years, what the standards of care for taking care of trans people were the Harry Benjamin standards of care. They're now known as the WPATH. What WPATH, the guidelines have required is, for many years, they required people to live a year as the gender that they were moving to, even before they could get such things as hormones and surgery, which, depending on your physical body, could be extremely difficult and extremely opening people up to public problems, violence and discrimination. And what still remains is that in many cases, surgeons in particular, and sometimes the physicians that prescribe hormones, require their patients to basically have a letter from a mental health therapist who has treated them for some period of time. And the letter needs to say, essentially, this person believes they're of the opposite sex, but they're still sane. It's the stamp of approval of it's okay to give hormones or do surgery, gender-related surgery on this person. Sometimes people need those letters from two therapists, depending on what the surgeon or the physician requires. So what that means is that transgender people, and this is truer in the past than it is now, have had to have relationships with therapists to even get the health care that they needed. Well, because the therapists had that gatekeeping to those important things that trans people wanted, trans people, the early literature from the people that work with trans people said they lied a lot. Well, they probably did because they didn't want to jeopardize their chances of getting hormones and surgery. We know people, because we do so much work with people with trauma histories, that many trans people never tell their therapists about their trauma history because of the possibility that the therapist would say, well, then you're not able to be, you're not a good candidate for hormones or surgery. Obviously, that means the therapy is less effective than it should be if you're hiding important things in order to present a facade to your therapist. But it also means that when we look at the statistics, that the number of trans people that have been in therapy is incredibly high, really, really high. So, but when there is, when you're not going to therapy for your letter, it's called the letter, like it had a big capital L, but you need a therapist for run-of-the-mill depression, or you've got couples therapy that you need to do, or something like that. There's all of this baggage of these were the people that held my identity and my history in their hands. So it's a really sticky relationship.
Yes. The word that stands out to me is trust, and the nature of putting therapists in a role of determining if somebody has the psychological capacity to endure a transition sets this dynamic of mistrust and fear in the relationship that needs to be the most trusted.
Right.
And so it would make sense to me that people would lie. Who do you lie to? People you don't trust.
Right.
And people who have power over you, who could harm you.
Right.
And so you'll do whatever it takes to keep safe and to get your needs met.
Right.
And that might include lying. And then, so if you do need mental health care down the road, you carry with you, we call it in therapy and psychotherapy transference, you carry with you that experience and you transfer it onto the new therapist, that mistrust and that the history of power imbalance and inequitable care. We don't put others through that same level of scrutiny. I can appreciate that there are so many barriers, and with a group of folks with high rates of trauma and with high rates of mistrust, my hope is that mental health can begin to shift and provide affirming, thoughtful, holistic care to trans folks, just as I would want for myself.
Right.
But it's not, the gatekeeper role is not as standard. Is that what you were saying?
Well, there's now more physicians and I think surgeons that are doing informed consent, which is the approach that the rest of us have all the time in medical care. The doctor says to you, well, I think you ought to be on this drug, but these are the possible side effects, and you get to make the decision. Are you going to accept those side effects? And that's what many people are moving to with trans people, is informed consent of, let's go over what these hormones will do and won't do, and what you can expect and what you're risking, and then you decide.
Yes. You understand the risks and benefits and you make a decision that's consistent with what you need. So what can then providers do to create affirming spaces? So what can mental health providers do to create affirming spaces and begin to shift the tide, so to speak?
Well, I do have some ideas. The very first thing, the most basic thing, is you have got to get the name and pronouns correct. This is not an option. You have to get the name and pronouns correct. And amazingly, even though sometimes it seems difficult, it actually only requires, what name and pronoun would you like me to use for you? And that's all it takes, except that you got to remember it. But that's critical. And then if you've got, I know a lot of mental health professionals work alone, but if you've got a receptionist or you work in a clinic or whatever, everybody else has to get that too. I mean, if somebody, I tell physicians, it doesn't matter how trans competent you get, if the receptionist makes a mistake when the patient first walks in, because the patient won't sit in the waiting room. They believe, so you got to have everybody trained. One of the things that we most emphasize with all kinds of healthcare professionals, including mental health professionals, is what we call know and tell why. Trans people get subjected to the most obnoxious questions about their genitals. Partners get asked questions about their partner's genitals. They get asked, what was your real name? They get asked a lot. We get asked a lot of really strange questions. And as a result, we really get our backs up around questions. We're really nervous. So what providers can do is think through the questions they're asking and figure out, how are you going to use this information? And how is this information going to benefit the client. For example, for a non-trans example, you're a benefits person, and you say to someone, in order to figure out if you're eligible for this program, I need to know your income. So it's different. It's a different question than what's your income. And so that's what providers need to do with the questions that they ask trans people. The reason I'm asking this is, and then ask the question, yes, because otherwise trans people are going to be, in general, I mean, this is generality, but are going to have their backs up. Like if it's not obvious why you're asking me this question, I'm going to worry that it's an inappropriate question, or you're just curious. And that happens a lot. I went in with my partner one time when he had one of those colds, head colds, that just, you can see it. You can just see it. And we went into the physician, and the physician said, "Why are you on testosterone?" And my partner said, "Well, I'm transgender." And the physician said, "Well, have you had surgery? Do you have a penis?" And it's like, we're here for a head cold. You can see we're here for a head cold.
My penis does not influence my sinuses. Thank you.
So when they get those kind of questions repeatedly, it really helps for providers to think through the question again, know and tell why. Why am I asking this question? And tell the client why. So that, and that builds trust. That builds trust. Privacy is even more important for most trans people than it is for non-trans people. I mean, we're doing HIPAA and stuff, but it's much more important. And one of the things that I notice with a lot of service providers is that they think they have to tell other service providers that someone is trans. Well, that's personal medical information, and maybe you don't have to tell them that. It definitely raises the exposure level of the trans person when people do that. Another thing is to follow the lead, particularly around body part names. If you're talking about body parts, follow the client's lead. If I have what you think are large breasts, and I call it my chest, call it my chest. Trans people often use body part names. They can make up new body part names. They can use other body part names. It's a way of helping cope with the body dysphoria. And so you can really show respect and cut down on the trauma. Because if I said, this is my chest, and you said, well, you're pretty big breasted, that can be traumatizing. And the last thing that I wanted to mention is be an advocate. Find out if your trans client would like your help. It needs to be with informed consent, but if they would like your help with something, because it is exhausting out there. I mean, and I think more people can get this now with COVID. It's exhausting out there. Well, it's been exhausting for trans people all along because you're navigating so much stuff. So if service providers can be advocates with consent, that can be really helpful.
When you say advocates with consent, give us an example.
This is not exactly on point, but we had a trans man that we were working with that had gone through attempted gender conversion as a kid. And it was really awful. And now he was having major, major depression issues, but he wouldn't go to a therapist because of his trauma history. And so we got his permission to talk with a therapist ahead of time. We got his permission to go with him to therapy. So that, it's almost literal hand holding.
Yes.
That's the kind of thing I'm talking about of helping interface with other systems.
Oh, thank you for that example. One of the things we talk about in mental health care as well, and in medical systems, is a warm handoff. Yes. And you use the trust that you've established with your client or patient, and by supporting them in moving into a new room, or if you're in the same medical system, or supporting them in starting with a new therapist and maybe having a group Zoom call, that you can help to transfer the trust that you and your client have established, or you and the transgender individual have established, and then transfer that trust to the new relationship. It just helps so much with the transitions of care. In fact, I was working with an older transgender adult. The therapist was leaving, and the therapist had worked with the older transgender adult for many years. The therapist was leaving the system and transitioning the older person to me. And we had an overlap meeting where I came into her therapy room, met the older transgender adult, answered questions, shared about myself, who I am, what my style is, just so the older transgender person could know me a little bit. And it wouldn't be so scary. It wouldn't be so foreign, unfamiliar. And then she was her preferred pronoun, would know where to go, would know who to look for, would have a sense of security when she got there. And it really helped. And then I worked with her for years. And then after that time, she didn't need as consistent therapy, but so we didn't have the same warm handoff because it wasn't needed anymore. But I would have done the same thing, and I had done the same thing with other folks. So thank you for saying that. So that is an act of advocacy, and it's an act of consideration for people with higher levels of trauma, higher levels of mistrust in a system, and just ways to build some bridges. So thank you for that, Loree. I really appreciate it.
It does remind me of something that I didn't say about providers that really is important, of know who your referral is. Make sure when you refer someone that they are trans competent. We recently had an experience, and I'm just telling you this because we're a trans organization and you'd think we had it all together. We had a psychiatrist recommended to us, and we wanted to have a Zoom meeting where the psychiatrist addressed medications with trans people. Since so many of us are on medications, not just hormones, but for our trauma stuff. Plus the normal things like high blood pressure and that sort of thing. And he said horrible things. He wasn't intending to, but he said horrible things. Like he said, well, he said to someone who asked a question, well, you're going to have to educate your psychiatrist. And we're like, no, by the time someone's going to a psychiatrist, they are not in a position to be educating their psychiatrist. And he said a number of things like that. And we were we were beside ourselves because we had some really fragile people on the Zoom, and we had to do a lot of work afterwards. And we went back to the person who had recommended him. And he says, well, I thought he was really good. Well, maybe in general, but he hadn't had a clue about trans people, and he didn't do any of his homework, and he did damage. So make sure your referrals are good.
Thank you. Yes.
And it can damage not only can a failed relationship with a new person, but it can blow back on you.
Yeah. And folks' trust with the system as a whole.
Right.
Was if the response is you have to educate your provider, that's saying providers are not educated.
Yeah, well. Yeah.
And are not going to be.
Right.
Yeah.
And aren't going to do their homework.
Right. So say we have a listener who is a family member and wants to learn more about creating an affirming space for their loved one, what would you recommend?
We have a self-help guide for partners of transsexual assault providers, which does talk a little bit about relationship issues. And I think any of the basic transgender aging publications that I sent to you might be helpful. The one resource that I particularly wanted to call attention to was I have a new transgender client. Now what? This one was written with a home health aide or a nursing home aide in mind, of answering the basic questions that tend to come up. What do I call my patient? Who should they room with? What am I going to see when their clothes are off? I mean, we went to some of those questions. What happens if my religion tells me, not that this is not a good thing? So that particular.
Can I stop you? That sounds like an incredible resource. I'm going to have a podcast just on that.
I'm very proud of that resource because I didn't find anything out there that was like that. And I think we need to provide that kind of assistance,
yes,
to the people that are taking care, because we don't think very much about training home health aides on this kind of stuff. We're training nursing home aides, and yet that's the kind of stuff they're going to think about. So that there's some basic stuff in there that family members might be able to use. But otherwise, I think we're again talking about use the pronoun and name and some of the basic respect issues.
Mm-hmm. And for partners, you were talking earlier about the tension between the identity tension.
Yeah. I really recommend that partners find at least an online group that supports partners of transgender people. Mm-hmm. Because I think the very first thing the partner of a transitioning person needs to know is some marriages make it. It is possible, because oftentimes people think, well, I have to divorce. And it's like, no, you don't. And we'll show you some marriages that survived. And then there needs to be a place to work through, does this mean I'm a lesbian? Do I have to identify as bisexual? What if I don't like their body when they're on hormones? This is the kind of thing that really needs to be worked through. A few couples can work through it together. A lot of couples, it seems, cannot work through it together. They need a separate place. Yeah. So I would really recommend that partners find places online where they can talk to other partners. And of course, we do always recommend therapy. But even then, it's, we've heard horror stories of therapists that, in fact, I went to an early conference where a therapist came in and it was a partners caucus, and she came in and said, "Get with it. You're supposed to support your partner." And it's like, no, I don't. I did feminist work for a long time. You don't come in and tell me what to do.
First of all, I decide. Second of all, hold space for me. Earlier, you mentioned Christine Jorgensen.
Yeah.
Tell us who she is.
Thank you for having me do that. She was a former GI that transitioned and had a surgery in Europe, and was the first really public transgender person when she came back to the U.S. So it's Christine Jorgensen. She was physically very beautiful, and she really caught a lot of people's attention because her transition made her look so different, and she was public about it. So that's the first time for most people. If you're old enough, that was probably the first transsexual you heard about.
Christine Jorgensen. Mm-hmm. Mm-hmm. You also shared with me that I will be sharing with our listeners a lot of resources that are so important. I'm just going to review a few of them because I really want our listeners to go and check them out. And these will all be available in the show notes on the Trans Aging Network, Elder TG, for transgender elders themselves, creating end-of-life documents, Medicare changes, transgender elders SOFFA roundtable. What is that?
SOFFA.
SOFFA.
SOFFA is significant others, friends, family, and allies. It was coined in 95, and it was basically an attempt to open the trans community, which at that time defined itself as just trans people. And we were trying to, make people understand that no, the family members were also affected.
Yes. Okay. And then for service providers, the guide that we talked about earlier, which I can't wait to read. I have a new transgender client. Now what? Then creating equal access to quality healthcare for transgender patients, transgender affirming hospital policies. That sounds fantastic. Inclusive services for LGBT older adults, a practical guide to creating welcoming agencies, quick tips for caregivers of transgender clients. Wow. And then because of, we'll be airing this right around Transgender Day of Remembrance, there are also really important guides and resources around improving the lives of older transgender adults, abuse and violence directed at transgender elders, and sexual violence, elder abuse, and sexuality of transgender adults age 50 and older, results of 3 surveys. Loree, cannot thank you enough for deepening my understanding, helping to reinforce the things that I do that are affirming, and also sharing with me other things that I can do, like holding space for the partner. I have shared this throughout this interview, but my hope is that as mental health providers, as senior care providers, that we will do a better job for our older transgender adults, that we will begin to dismantle some of the stigma that plagues all of our systems, and keeps people out of care, and increases disability as a result, and increases poverty as a result. And I just thank you so much for the work that you do and for educating us today. And I can't wait to read all of these resources and to share them on the show notes page. Thank you so much.
All right. Well, thank you. This has been a lovely interview.
If you have not yet seen my new mentalhealthandaging.com website, I really encourage you to check it out. There are tons of great resources and information there for you. I have a great new guide called the Memory Loss and Mental Health Guide. In that guide, I share signs and symptoms of dementia. I share signs and symptoms of depression and mental health concerns, and what to do if you're concerned about your older loved one. If you're noticing signs of memory loss or mental health concerns, download that free guide as well. I'll link to that in the show notes too. Oh, and if you haven't yet subscribed to this podcast, please, please, please subscribe. It really helps other people to find this show. I really want people to feel less alone in their caregiving journey. I want older adults to feel less alone in their mental health journey, in their dementia journey, if they have that. So please subscribe and leave a review. It really does help. All right, I'll see you next week, same time, same place. Bye for now.